Medication administration is a cornerstone of modern healthcare. It is an act of trust between a patient and a clinician. Every day, millions of doses are given, bringing healing and relief. Yet, within this routine process lies a hidden risk. Medication errors are a serious global problem. They can cause harm. They can prolong hospital stays. They can sometimes lead to tragic outcomes. We have long relied on the vigilance of dedicated healthcare professionals to prevent these errors. We teach them the 5 rights of medication administration. Right patient, right drug, right dose, right route, right time. These principles are fundamental and important in their own way, but human memory is fallible. Under pressure, during a long shift, faced with constant interruptions, the traditional approach places a heavy burden on the individual. It suggests that perfect performance is the only barrier against error. This is an unrealistic expectation in a complex healthcare environment. We need a better way. We need a stronger, more reliable approach to patient safety. The solution is not to demand more from our clinicians. The solution is to build better, smarter, and more resilient systems around them to prevent errors from ever occurring. This is a story about reimagining medication safety for the 21st century. We will explore how we can move beyond a framework that relies solely on memory. We will introduce a new perspective, one grounded in systems thinking. The Institute for Safe Medication Practices, the Joint Commission, the World Health Organization, the WHO has set an ambitious goal to reduce severe preventable medication-related harm by 50% globally. Achieving this goal requires a fundamental shift in how we think about safety in our daily work. In this journey, we will transform the familiar 5 rights. We will see them not as individual rules to be memorized, but as 5 interconnected systems of safety: identity system, selection system, calculation and delivery system, context system, transition system. Each system is a layer of defense. Each one is designed to catch errors before they can reach the patient. We will see these systems in action: barcode medication administration, smart pump alerts, clear syringe labeling, pharmacist-led medication reconciliation. These are the tools that build a powerful safety net. Our central thesis is simple, yet profound. Robust systems, not human memory, are the key to drastically reducing medication errors. When we design our workflows with safety in mind, we create an environment where doing the right thing is easy and doing the wrong thing is difficult. This isn't about replacing clinical judgment, it's about augmenting it. We provide clinicians with the tools and support they need to deliver care safely and effectively every single time. This shifts focus from blaming individuals to examining and improving the processes in which they work, creating a culture of safety. Throughout our exploration, we'll see real-world examples and the technology that powers them. 5 rights transforming into 5 interconnected gears. Imagine a nurse scanning a medication barcode. The system instantly confirms it's the correct drug for the correct patient. Selection system and identity system working together. Identity system, selection system, calculation, delivery system, context system, transition system. Think of a pharmacist programming a smart infusion pump. A built-in library with hard limits prevents a dangerous overdose. Calculation and delivery system as a critical safeguard. These are practical solutions used in hospitals today. We'll also confront what happens when systems fail or are missing. Dramatize near-miss scenarios. Errors caught just in time. Nurse nearly grabs a look-alike vial before a barcode scan stops her. Pharmacist catches a dangerous drug interaction during medication reconciliation. These stories highlight vulnerabilities in current processes. More importantly, they show the life-saving power of well-designed safety systems. They show why we must move beyond old habits. Our journey is guided by current clinical guidelines, recommendations from ISMP, standards from the Joint Commission, global initiatives from WHO, specialized rules like USP 800 for hazardous drugs such as chemotherapy. By the end, you'll not just understand the 5 rights differently. You'll see them as a blueprint for building a safer medication administration process. You'll have a clear, actionable vision to protect patients and support clinicians. Safety built into the fabric of care. The first most fundamental principle of medication safety has always been to treat the right patient. This sounds straightforward. It seems like the simplest check to perform. Yet, in the fast-paced, often chaotic environment of a hospital, confirming patient identity is a complex task. Patients move between rooms. They might be disoriented or unable to communicate clearly. Wristbands can be damaged. Wristbands can be removed. Wristbands can be placed on the wrong person.
What's your name? Relying on a simple verbal confirmation or a glance at a room number is a fragile process.
It is a system built on assumptions, and assumptions are where errors begin to take root. We must reimagine this first right. It is not just a single action, but a dynamic, technology-enabled process. We call it the identity system. This system's purpose is to create an unbreakable link between the patient, their medical record, and the medication they are about to receive. The goal is to make positive patient identification an active, required, and verifiable step in the workflow. It shifts the responsibility from a clinician's memory to a reliable, interconnected technological loop. The system doesn't just ask, "Is this the right patient?" It proves it with digital certainty every single time. This is a critical first line of defense. The core of a modern identity system is barcode medication administration, or BCMA. This technology creates a closed loop of verification. The process starts with the patient's unique identification wristband, which contains a barcode. Before any medication is given, the clinician scans this barcode. Then, they scan the barcode on the medication itself. The electronic health record acts as the brain of the system. It instantly compares the scanned information against the physician's order. If the patient, drug, dose, route, and time all match the order, the system confirms it is safe to proceed. It's a digital handshake that ensures every element is correct. This systematic approach is strongly endorsed by leading safety organizations. The Joint Commission has long emphasized the importance of using at least 2 patient identifiers before administering medications. These identifiers can be the patient's name and date of birth, for example. The BCMA process automates and elevates this standard. It makes the 2 identifier check a mandatory scannable action, rather than a mental checklist item. The Institute for Safe Medication Practices has documented countless errors prevented by this technology. The identity system transforms a moment of potential human error into a moment of confirmed safety, setting the stage for the rest of the medication process. Let's consider a near-miss scenario, a story that plays out more often than we would like to admit. Mr. Johnson in room 402 is recovering from knee surgery. Mr. Johnston in room 408 is being treated for a heart condition. A nurse, carrying a dose of a powerful beta blocker intended for Mr. Johnston, enters room 402 by mistake.
Are you Mr. Johnson?
The patient, groggy from pain medication, simply nods. The nurse is about to administer a drug that could cause a dangerous drop in blood pressure and heart rate in this post-operative patient. In a system reliant on memory and manual checks, this error might have occurred. The similar sounding names and the patient's non-specific confirmation create a perfect storm for a mistake. But in this hospital, a robust identity system is in place. Before administering the drug, the nurse follows protocol. She scans the patient's wristband. Immediately, a loud, clear alert appears on her screen. Wrong patient. The screen displays the intended patient's name, Johnston, alongside the scanned patient's name, Johnson. The system has broken the chain of error before it could lead to harm. This is not luck. This is safety by design. This example highlights common failure points in patient identification. Look-alike names are a well-documented risk. Sound-alike names are a well-documented risk. The ISMP recommends using tall man lettering in electronic systems to visually distinguish similar names. Another vulnerability is patient movement. Patients are frequently transported for tests or procedures. Room numbers can become unreliable identifiers. A patient may be temporarily in the hallway. A patient may be in a different unit. Without a positive, patient-attached identifier like a wristband, the risk of a mix-up increases dramatically. The system must be tied to the person, not the location. Furthermore, the patient's condition can compromise traditional verification methods: confused, sedated, nonverbal. Active confirmation from the patient should be seen as a final, helpful layer, not the primary method of identification. The system must be designed to function perfectly, even when the patient cannot respond. Including a patient photograph in the electronic health record provides another powerful visual confirmation. The combination of a mandatory scan, 2 identifiers, and a photo creates a multi-layered defense that is far stronger than any single check performed from memory. To build an effective identity system, we need to embed specific practices and technologies into our daily workflows. The foundation is the mandatory Scan, Match, Ask protocol. Scan, match, ask. First, scan the patient's barcode. This is a non-negotiable step. Second, the system must match the patient to the medication order in the EHR. This automated check is the system's core function.
Can you please state your full name and date of birth?
This 3-step process is simple, repeatable, and highly effective. System configuration is also crucial. Alerts must be clear. Alerts must be intrusive. Alerts must require action. A small, easily dismissed notification is not enough. The alert should be a hard stop. Clinicians cannot proceed in the EHR until the discrepancy is resolved. This forces a pause and a re-evaluation. It prompts the nurse to step back, re-verify the patient's location, check the chart, and understand why the system flagged an error. This deliberate pause is where safety happens. Beyond technology, organizational policies must support the identity system. Hospitals need clear procedures for a missing wristband and for a damaged wristband. There must be a standardized rebanding process with 2-person verification to confirm the new band. Policies must cover edge cases like unknown John Doe patients and newborn infants without a name. These edge cases need planned, safe protocols to maintain identity integrity for every patient. Ultimately, the identity system is about creating certainty. It replaces ambiguity with data. It turns, "Am I at the right bedside?" into, "This is the right patient." Implement mandatory barcode scanning, use at least 2 identifiers, incorporate patient photos, and design powerful alerts. Together, these build a formidable wall of identity. This first system of safety ensures medication administration starts with absolute correctness. It is the essential first step to eliminate preventable medication harm and protect patients. Once we have confirmed we are with the right patient, our focus shifts to the medication itself. The second traditional right is administering the right drug. This single phrase encompasses a complex chain of events that begins long before a nurse reaches for a vial. Physician's order, pharmacy verification, and dispensing process, final selection at the patient's bedside. Each step in this chain presents an opportunity for error. A confusing abbreviation in the order, a misread label in the pharmacy, a moment of distraction in the medication room. This can lead to the wrong drug being chosen, with potentially devastating consequences for the patient. To address these vulnerabilities, we must think beyond a simple check. We need a comprehensive selection system. This system is a series of interconnected checks and balances designed to ensure the medication ordered by the physician is the exact one that is prepared, dispensed, and ultimately administered. It is a safety net woven from standardized processes, technological verification, and expert oversight. The goal of the selection system is to make it difficult to choose the wrong medication and easy to choose the right one. It achieves this by building layers of defense that can catch an error at any point along the medication use pathway, from the pharmacy to the bedside. A robust selection system begins with a clear and unambiguous medication order. The use of error-prone abbreviations is a well-known source of confusion, like U for units or QD for once daily. The Joint Commission has a do not use list for this very reason. Modern electronic health records help enforce this by requiring physicians to choose from standardized, pre-programmed medication lists, eliminating illegible handwriting and eliminating ambiguous terminology. The pharmacy then plays a crucial role. Pharmacists verify the appropriateness of the order, checking for allergies, contraindications, and potential interactions, acting as a critical clinical gatekeeper in the process. The physical form and storage of medications are also key components of the selection system. Dispensing medications in unit dose packages drastically reduces the risk of mix-ups. Each tablet or vial is individually wrapped and barcoded, compared to dispensing from large stock bottles. Furthermore, guidelines like USP 800 mandate the segregation of hazardous drugs, such as chemotherapy agents. These medications must be stored in separate, clearly labeled areas to prevent accidental exposure or administration to the wrong patient. These physical and logistical controls are deliberate, system-level designs to prevent catastrophic errors before they can happen. One of the greatest challenges within the selection system is the problem of look-alike and sound-alike medications. The pharmaceutical industry produces thousands of drugs, and many have names that sound similar and packaging that looks nearly identical. For example, the sedative hydroxyzine can easily be confused with the blood thinner hydralazine. A mix-up could lead to a patient being overly sedated or experiencing a life-threatening drop in blood pressure. These pairs are traps for a busy or distracted clinician. Relying on memory alone is a high-risk strategy. The Institute for Safe Medication Practices maintains an extensive list of confused drug names. One effective strategy is tall-man lettering. This visual cue capitalizes parts of a drug's name, as in hydroxyzine and hydralazine. Apply it to electronic prescribing systems, pharmacy labels, automated dispensing cabinets, and patient medication lists. It draws the eye to differences, reducing the chance of selection errors. Beyond naming conventions, technological safeguards are essential. Barcode scanning at the point of administration is the ultimate backstop. When a nurse scans a unit dose barcode, the system verifies it against the electronic order. If vincristine is picked instead of vinblastine, the system triggers an immediate hard stop alert. This turns potential human error into a verified, safe process. The barcode reads the drug's digital identity with complete accuracy. Organizational strategies also matter. Separate look-alike drugs on storage shelves or in automated dispensing cabinets. Add brightly colored, laminated warning labels to storage bins. Involve frontline staff in identifying LASA pairs in their formulary. Combine tall-man lettering, barcode verification, and smart storage to create a multi-pronged defense against LASA errors. Imagine a nurse on a busy oncology unit, preparing a dose of chemotherapy. The patient is scheduled to receive vinblastine. The nurse goes to the medication room, which is kept separate and secure according to USP 800 guidelines. She is wearing the appropriate personal protective equipment. Gloves. A gown. She finds the medication in the refrigerated section for hazardous drugs. She pulls out a small vial and is about to draw up the dose. The vial is small. The text is tiny. She is working under pressure. She has accidentally grabbed a vial of vincristine, a different chemotherapy agent with a much lower typical dose. Administering this would result in a massive overdose. In a system without robust checks, this mistake could have easily reached the patient. The nurse is careful and well-trained, but the similar names and packaging create a subtle trap. However, this hospital has implemented a comprehensive selection system. The nurse's next step, as ingrained in her workflow, is to perform a barcode scan before preparing the medication. She takes the vial to the counter and scans its barcode. Instantly, her computer screen flashes with a red warning. Drug mismatch. Ordered vinblastine. Scanned vincristine. Do not administer. The system has caught the error before the vial was even opened. This near-miss scenario perfectly illustrates the power of the selection system. It shows how technology acts as a safety net, catching a mistake that the human eye might miss. The barcode scan is not just a perfunctory task. It is a critical verification step that confirms the identity of the drug against the physician's order with digital precision. This step is particularly vital for high-alert medications like chemotherapy. The system provides a moment of forced pause, a confirmation that prevents a well-intentioned clinician from making a terrible mistake. This is safety by design, not by chance. This event also highlights the importance of the environment. Proper PPE, a segregated preparation area for hazardous drugs, as per USP 800. While it didn't prevent the initial selection error, it ensured the process was being conducted in a manner that protected the healthcare worker. The real hero of the story, however, is the mandatory barcode verification step. It served as the final, definitive checkpoint. It demonstrates why the most effective safety strategies build reliable, verifiable, and unforgiving technological checks into the standard workflow. Forging a system of selection. Building a truly effective selection system requires a coordinated effort across multiple disciplines, including physicians, pharmacists, nurses, and IT specialists. The first pillar is standardized ordering. This means moving away from handwritten orders, stopping the use of error-prone abbreviations, and fully embracing computerized physician order entry, or CPOE. A CPOE system should be configured with standardized drug names, intelligent dose suggestions, and clinical decision support alerts. These are alerts that flag allergies and drug interactions. This cleans up the input, making the signal to the pharmacy clear and safe. The second pillar is pharmacy-led verification and technology. This includes the pharmacist's clinical review of every medication order, an indispensable safeguard, supported by technology. Automated dispensing cabinets, or ADCs, can enhance safety by requiring the user to select a patient profile before access and limiting access to only the drugs ordered for that patient. Hospitals should integrate barcode scanning into the pharmacy's workflow to verify meds as they are restocked into ADCs and during unit dose preparation. The third pillar is smart technology at the point of care. Beyond barcode scanning for verification, smart infusion pumps with dose error reduction software, or DERS, are a key component. These pumps house a hospital-specific drug library with pre-programmed names and concentrations. When the nurse selects a drug from the library, the pump automatically knows the standard concentration and can alert on out-of-range doses. This includes soft limit functionality and hard limit functionality, providing a final electronic safety check that the right drug is being given at the right concentration. The selection system is a chain of verification. It starts with a clear electronic order. It is vetted by a pharmacist. It is dispensed using barcoded unit dose packaging. It is stored intelligently to prevent mix-ups. And it is confirmed at the bedside with a mandatory barcode scan linking back to the original order. Each step is a link in the chain, and each link is a potential point of failure. By fortifying every link with standardized processes and technological safeguards, we create a resilient system that makes it incredibly difficult for the wrong drug to ever reach the right patient. Once we have confirmed the right patient and selected the right drug, we face the next critical challenge: ensuring the right dose and right route. These two rights are inextricably linked, forming the core of what we will call the calculation/delivery system. This system governs the final physical act of medication administration, the precise measurement of a dose, and its delivery to the patient via the correct pathway: a tablet to be swallowed, a cream to be applied, or a solution to be infused intravenously. Errors in this phase can be just as dangerous as selecting the wrong drug, turning a therapeutic dose into a toxic one with a misplaced decimal point or a misconnected tube. The calculation/delivery system is designed to defend against these specific types of errors. It recognizes that calculating doses, especially for pediatric patients or for complex infusions, is a high-risk cognitive task. It also acknowledges that the physical delivery of medications, particularly through intravenous lines, is prone to mix-ups and misconnections. The system's purpose is to replace mental math with verified calculations and to make the delivery pathway clear and unambiguous. It uses technology and standardized processes to build guardrails that guide the clinician toward the correct dose and route, preventing devastating errors before they can happen and ensuring the medication is delivered exactly as intended. A fundamental component of this system is the principle of standardized concentrations. For many high-risk intravenous medications, hospitals can and should establish a single, standard concentration to be used throughout the institution. This eliminates the need for nurses to perform complex dilution calculations at the bedside, a common source of error. When the pharmacy prepares all infusions of a certain drug, like heparin or insulin, in the same standardized bag, the calculation becomes much simpler and safer. It shifts the complex preparation work to a controlled pharmacy environment, providing the nurse with a ready-to-administer product that is far less prone to dosing mistakes during the final setup. Another critical practice within the calculation/delivery system is the mandatory labeling of all medications prepared by a clinician. Any medication drawn into a syringe, for instance, immediately loses its original identity once it is separated from the manufacturer's vial. An unlabeled syringe is a mystery, a potential for catastrophic error. The Joint Commission mandates that any medication prepared and not immediately administered must be clearly labeled with the drug name, strength, and other key identifiers. Providing pre-printed, easy-to-use labels encourages this behavior, transforming a dangerous unknown into a clearly identified, safe dose, ready for administration. This simple act of labeling is a powerful defense against mix-ups. Let's witness a near-miss scenario that underscores the importance of a robust calculation delivery system. A patient in the intensive care unit requires a continuous infusion of a potent vasoactive drug to maintain their blood pressure. The order is for 12 milliliters per hour. The nurse, who is managing multiple complex patients, begins to program the intravenous smart pump. In a moment of haste, she accidentally enters 120 instead of 12. She has just programmed a 10-fold overdose. This is one of the most common and dangerous types of errors in medication administration. A simple slip of the finger with potentially fatal consequences for the patient. In an older system using a basic infusion pump without safety software, this error would have gone unnoticed. The pump would have begun delivering the massive overdose, and the patient's blood pressure would have skyrocketed, likely causing a stroke or other severe harm before the error was discovered. However, this ICU is equipped with smart pumps that have dose error reduction software, or DERs. The moment the nurse tries to confirm the rate of 120 milliliters per hour, a loud alert sounds. The pump's screen flashes with a red warning. Hard limit exceeded. Rate is above maximum safety limit. Reprogram required. The pump will not start the infusion until the rate is corrected. This powerful intervention illustrates the core function of a smart pump's drug library. The library is customized by the hospital's pharmacy for every high-risk medication. For each drug, pharmacists program soft limits and hard limits. A soft limit generates a warning for a dose that is outside the normal range, but allows the clinician to override it if clinically appropriate, requiring a conscious confirmation. A hard limit, as seen in our scenario, is an absolute ceiling. It represents a dose so high that it is almost certainly an error and cannot be overridden. This feature provides an unforgiving electronic backstop that protects patients from the most dangerous decimal point and keystroke mistakes. This near miss highlights why organizations like the ISMP strongly advocate for the universal use of smart pumps with fully implemented drug libraries. Relying on a human double check, while better than no check at all, is still a fallible process. Two clinicians can make the same mistake, a phenomenon known as redundant error. The smart pump, however, is an independent, unbiased checker. It doesn't get tired, distracted, or intimidated. It simply compares the programmed dose against its established safety rules. The hard limit alert didn't just prevent one error, it saved a life by transforming a simple human slip into a non-event, a corrected mistake with no harm done. Building a comprehensive calculation delivery system requires a multifaceted approach that combines technology, process, and practice. The first step is the widespread adoption of smart pumps with their DERs drug libraries fully activated and maintained. It is not enough to simply own the pumps. Compliance with using the safety software must be high. Hospitals should monitor this compliance and provide ongoing education to ensure nurses are consistently using the drug library for every infusion. This technology is the single most effective tool we have to prevent intravenous medication dosing errors and must be the cornerstone of any modern delivery system. The second critical element is a standardized process for handling high-alert medications. ISMP and the Joint Commission recommend high-alert drugs such as insulin, narcotics, and anticoagulants require an independent double check before administration. While a smart pump provides a technological check, a structured human double check adds another layer of safety. This should be an active, independent check where a second nurse recalculates the dose or verifies the pump settings without being influenced by the first nurse. This structured pause creates another opportunity to catch an error before it reaches the patient. The third component addresses the right route by focusing on the physical lines and connections. A patient in a critical care setting may have multiple intravenous lines for different medications. This creates a spaghetti syndrome, where it becomes easy to connect the wrong line or confuse one infusion for another. A critical safety practice is to trace the line. Before starting any new infusion or making a change, the clinician physically traces the tubing with their finger from the pump all the way to the insertion site on the patient's body. This simple tactile act confirms the medication will be delivered to the correct vascular access site, preventing dangerous misconnections. In the end, the calculation delivery system is about creating layers of defense around the riskiest parts of medication administration. It leverages standardized concentrations to simplify preparation. It uses smart pumps with hard limits to catch deadly dosing errors. It implements structured double checks for the most dangerous drugs, and it demands the physical tracing of lines to ensure the right route. By designing these checks and balances into the workflow, we offload the burden of perfect calculation and flawless execution from the individual clinician. We create a system where the safe path is the easy path, ensuring every dose and every route is confirmed, correct, and safe. So far, we have built systems to ensure the right patient, right drug, right dose, and right route. But there is another dimension to safety, the context of administration. This brings us to the traditional right time, but it's broader than the clock on the wall. A medication given at the correct time but during a moment of extreme distraction is not truly safe. A dose administered correctly, but without considering the patient's current clinical status, is a potential risk. We must expand our view to encompass the entire clinical environment. This is the purpose of the context system, to ensure medications are given at the right time and under the right circumstances. The context system acknowledges the environment of care profoundly impacts safety. Constant interruptions are a major threat to concentration during medication administration. A nurse stopped multiple times while preparing or giving a drug is more likely to make a mistake, like forgetting a dose, giving it twice, or making a calculation error. The context system seeks to create a protected space and time for this critical task. It involves physical changes, like no interruption zones, and cultural changes to signal medication administration is high risk and should not be interrupted. This is about respecting the sanctity of the process. One strategy is using visual cues, like a red sash worn by the nurse during medication rounds. That sash sends a clear, non-verbal message to colleagues, patients, and families. It empowers the nurse to delay non-urgent conversations and focus fully on the 5 systems of safety. Another key part is the high alert pause. This is a deliberate, mindful stop before administering any high alert medication, even after checks are complete, to consider the big picture. Does this dose make sense given the patient's latest lab results? Is their blood pressure stable enough for this antihypertensive? This pause for critical thinking is essential. It ensures the medication is appropriate for the patient in that exact moment, ensuring the context is right for safe administration. Patients are not static. They move through the healthcare system, from the emergency department to an inpatient unit, to the operating room and back home. At each of these handoffs, or transitions of care, the patient's medication list is at high risk of falling apart. Information can be lost, duplicated, or misinterpreted. A home medication might be incorrectly continued in the hospital, or a new hospital medication might be accidentally omitted from discharge instructions. These transition-related errors are incredibly common and can cause significant harm. This is why we need a dedicated 5th system, the transition system. The transition system is a formalized process for managing medications across every change in care setting. Its primary tool is medication reconciliation. As defined by the Joint Commission and the World Health Organization, medication reconciliation is the process of creating the most accurate list possible of all medications a patient is taking. This list is then compared against the physician's admission orders, transfer orders, and discharge orders. The goal is to identify and resolve any discrepancies, additions, omissions, or changes. before they can cause harm. This is not a simple administrative task. It is a critical clinical investigation that ensures continuity and safety as the patient moves. Let's consider a near-miss vignette. An elderly patient with diabetes is admitted to the hospital. At home, he takes a specific type of long-acting insulin every night. During a rushed admission process, this detail is missed. The inpatient physician, unaware of the home regimen, orders a standard sliding scale insulin protocol based on the patient's blood sugar readings. Without the long-acting insulin, the patient's blood sugar becomes dangerously high overnight. However, in this hospital, a pharmacist-led medication reconciliation is a standard part of the admission process. The pharmacist sits with the patient and his family, carefully reviewing all home medications. The pharmacist discovers the discrepancy. The patient's home long-acting insulin is not on the current inpatient order set. She immediately contacts the physician. They discuss the patient's history, and the physician agrees that continuing the home regimen alongside a corrected sliding scale is the safest and most effective plan. The order is updated, and a potentially serious episode of hyperglycemia is averted. This story shows the transition system in action. The pharmacist, acting as a medication expert, bridged the information gap between the patient's home environment and the hospital, preventing a serious error and ensuring the plan of care was truly correct. To build an effective transition system, medication reconciliation must be structured, reliable, and owned. The most effective models are pharmacist-led. Pharmacists have the deep pharmacological knowledge required to not just list medications, but to understand them. They can ask clarifying questions, identify duplications in therapy, and spot potential interactions that others might miss. Making a pharmacist responsible for the definitive medication list at key transition points, admission, transfer between units, and discharge, creates a powerful safety net and a single source of truth for the entire care team. Technology can and should support this process. An ideal electronic health record would allow for a seamless flow of medication information, pulling in data from outpatient pharmacies and previous hospital visits to help build the initial home medication list. The system should then provide a clear, user-friendly interface for the clinician to compare this home list against inpatient orders, highlighting any discrepancies and requiring a resolution for each one. At discharge, the system should generate clear, patient-friendly instructions that explain which medications to stop, which to start, and which to continue, leaving no room for ambiguity. The process must be just as robust at discharge as it is at admission. A patient leaving the hospital with a confusing list of new and old medications is being set up for failure. Clear discharge instructions are paramount. These should be written in plain language. Use a teach-back method where the patient or a family member explains the medication plan back to the nurse or the pharmacist to confirm understanding. Provide a printed schedule with times and doses. Ensure the safety of the transition system extends beyond the hospital walls and into the patient's home. Maintain a complete and accurate story of a patient's medications. Close the gaps through which critical information can fall. Implement a pharmacist-led reconciliation at every handoff, supported by intelligent technology, and finalized with clear patient education to prevent a huge category of medication errors. This fifth and final system ensures hospital safety follows the patient wherever they go next, creating a continuous, unbroken chain of safe medication use. We began this journey by challenging a long-held belief in healthcare that the vigilant, perfectly performing clinician is the primary defense against medication errors. We have seen that while human dedication is essential, it is not enough. Memory is fallible, and complex environments create opportunities for mistakes. The true path to safer care lies not in demanding perfection from people, but in building perfection into our processes. We have reframed the traditional 5 rights not as rules to be memorized, but as 5 dynamic, interconnected systems of safety: the identity system, the selection system, the calculation delivery system, the context system, and the transition system. They work in concert to create a powerful, resilient safety net for every patient. These systems are the new standard of care. The identity system uses barcode scanning to create an unbreakable link. The selection system leverages pharmacy oversight and technology to neutralize the threat of look-alike, sound-alike medications. The calculation delivery system employs smart pumps to prevent catastrophic dosing errors and ensure the correct route. The context system creates a protected environment. The transition system bridges the dangerous gaps in care. Together, they form a comprehensive strategy for safety. This approach brings us closer to the World Health Organization's ambitious goal of reducing severe, preventable medication-related harm by 50% globally. The practical takeaways from these systems are clear and actionable. First, scan match. Ask to confirm patient identity with certainty. Second, high alert pause to think critically before administering high-risk drugs. Third, label everything you prepare to avoid dangerous mix-ups. Fourth, trace lines from pump to patient to guarantee the correct route. Finally, always confirm effect by monitoring the patient, closing the loop of care. Ultimately, preventing medication errors is a shared responsibility, but it is one that must be supported by intelligent design. We must shift our focus from blaming individuals to improving the environment in which they work. Embracing technology, standardizing processes, and fostering a culture where safety is built into every step. By doing so, we can create a healthcare system that is profoundly safer for our patients and more supportive for our clinicians. The future of medication safety is not about trying harder. It is about working smarter. It is about designing systems that make the right choice the easy choice every single time. This is our promise to the patients who place their trust in our hands.